So in the next section, let's be data-driven. Let's talk about 3 trials, and I'll start with Brian and then go to Danny and then to Jan. Let's talk about how you integrate ComPARS, Brian, into your decision-making, and whether you choose to use sunitinib or pazopanib at your own institution. Help the viewer understand how to understand that data in the context of what to offer their patient.
Sure. So ComPARS was, a very large, over 1,100 patient non-inferiority trial of sunitinib versus pazopanib, frontline metastatic clear cell RCC. What it showed was non-inferiority of pazopanib to sunitinib for PFS, and then also for OS data, which was released in interim fashion initially, and then actually was just recently updated in New England Journal. There's a lot of things about the trial you can pick apart in terms of the statistics of the intent to treat analysis versus a per protocol analysis, et cetera. The boundary for non-inferiority could be up to 1.25, meaning the drug could be as much as 25% worse. So the individual patient or clinician can decide whether that's acceptable. I think as sort of the dust settles on this and I think about it, it shows that they're both effective agents in the initial treatment of kidney cancer. And I think, the debate about drug A or drug B is not really where we should be focusing our mental energy. We're going to talk about new drugs where there's a lot of excitement, and we should be spending more energy either thinking about new drugs or thinking about how better to deliver old drugs, including dose individualization and things like that. But they're both effective agents, and I think either one's a reasonable choice.
So really, from a practical perspective, it's almost choose an effective agent, get comfortable with it, know how to use it, know how to modify the doses where necessary, understand the side effect profile, and that's probably as important as A versus B. Jan?
It's way more important, yeah.
Yeah, I agree with you both, and I would just like to say that when these drugs first became commercially available, outside of the clinical trials and the centers that had familiarity with them, the patients were coming off drug within a month. It was, whereas the median on study with the first sunitinib trial was 8 months, in second line. So the problem was a learning curve of how to keep people on the drugs and manage the patients. And I agree completely with Brian. You as a clinician have to get comfortable with one or the other or both, and know how to use it and know how to keep the patient on the drug.
So Danny, I think the RECORD-3 trial, is informative because we still get questions about, well, maybe we can use an mTOR inhibitor in good and intermediate prognosis patients. And the RECORD-3 trial was a trial that started off, even though it was a phase 2 sequential trial, of a comparison between mTOR inhibition with everolimus versus a VEGF receptor inhibition with sunitinib. How do you interpret those results and those findings?
Sure. So the RECORD-3 trial looked at first-line treatment with sunitinib followed by everolimus versus the opposite sequence, everolimus followed by sunitinib. And it actually showed that it actually reaffirmed our current practice, where starting off with everolimus is not superior to starting off with sunitinib. And so it reinforces our practice that we can start with the TKI first and in good and intermediate risk patients, and switch to an mTOR inhibitor afterwards.
And then, Jan, I'm always intrigued by trial designs, and the switch trial is a sequential study of sorafenib followed by sunitinib or sunitinib followed by sorafenib. How do you interpret that data?
Well, I like to call it the so-su-su-so approach. And my interpretation is that both drugs are active, and perhaps in a given individual, one sequence is better, and perhaps it isn't in another. So to me, it's the same as what you were talking about with ComPARS. They're both active drugs. You could give it in the sequence that you are most comfortable in, and they're going to be pretty much non-inferior.